introduction, then it will start from the beginning.
Right.
Yes, we are live now. Jasmine, you may start.
Hello, everyone. I'm back with Dr. Paul L. Ouellette. Talking about him, he is an ABO certified orthodontist, AAID credentialed implant dentist, educator, humanitarian, and author. Throughout his 5-decade career, Dr. Ouellette has been a leading proponent of implementing cutting-edge technology applications in dentistry. Over the past several years, Dr. O has been leveraging technological innovation to improve adjunctive orthodontics and implant dentistry. His passion for technology and implant dentistry led Dr. O to develop his own temporary anchor device, implant technology that plants. He has been an associate professor and the first clinical director at the Georgia School of Orthodontics and a clinical instructor at Jacksonville School of Orthodontics. Dr. O is also the founding principal of dentalspecialist.com, an organization that provides 3D CBCT multi-specialty dentistry to Central Florida. So today he'll be talking about orthodontics and implant dentistry. Over to you, sir.
It's fantastic. Thank you so much for the introduction. And I want everybody to bear with me because I'm a new Zoom user, and we'll just see how we do here. So my presentation today was one that I've been working on for more than 10 years, as there's 26 case reports, but don't worry, I'm not going to bore you with all the cases. We're just going to do one case so I can kind of show you the workflow that my sons and I developed over the last 10 years. So a little bit about myself and the family. I have been teaching in 3 different orthodontic programs and also in private practice. This is year 50 for me right now as a dentist. So this is a very busy slide, but it kind of shows the progression from raising my 2 dentist sons. And I have a daughter as well. She was supposed to be our oral surgeon, but she ended up in advertising in New York after 4 years of pre-dental school. Maybe I'll still get her to be the oral surgeon we'd like her to be. But I have one son that's an orthodontist, and he has 2 children, grandbabies that we are taking care of now. Also, my other son just had twins about 3 months ago, and he has another child. So we have 5 active grandbabies that we're raising right now. And I'm still flying to Atlanta, practicing with a large orthopedo group. We have 150 offices. I believe it's 150. And it's a great group because I get a lot of patients that need implants, and we're using implants in kids from maybe 12 and up. And we'll go over that as we go along. So I want to tell you about my son. He's a super implant dentist. He's in the center there. He was the chief resident with Dr. Mike McCracken and Dr. Rosenstiel. They were his 2 mentors and teachers at the Foundry Charity Dental Clinic. And he did so much implant dentistry in his AEGD residency. It was a 1-year residency. He ended up knowing how to do sinus lifts, all kinds of grafting procedures. And he does hybrid dentures now. And I'll explain as we get on the type of cases that he's doing. This was where my last practice was. I sold all my practices in 2015, May of 2015, it's coming up on 5 years. And went to Jacksonville University to teach for a couple years. And then I got recruited to Atlanta to work at the Georgia School of Orthodontics. There was only 3 of us to open the program. We had 18 residents and 2 fellows to start. And now it's in its 3rd year, just got its certification last year. There's 54 residents. I'm glad I'm not there anymore. I don't know if I could teach with so many residents. But it's a great program, and love the experience I got working with residents. So now we're in a COVID virus pandemic, and it's really tough out there for dentists because it might not be safe, completely safe for us to go back to business as usual. So we're going to have to make some changes. And I went through a disaster in my practice in Brevard County, Florida, where the Space Center is. And all my patients were from the Space Center. So you can see the from bad to worse, all the layoffs and everything. And my practice revenues decreased by 1.1 million in a year and a half. And that was really tough to try to keep everybody on. I didn't lose any of my employees. I lost my profit sharing plan to stay open. And so I've been through one, really tough financial time, and hopefully we're not going to see that again. I think we can work together and come out of this with everybody doing well in the future. Okay, my arrows are not working, so I'm pushing the wrong arrows because I'm not used to the Zoom here. So let's get to the next slide. Oh, actually, this had a little bit of video in it and everything, but we'll get by that. So this was the building from the front. It was on the Indian River. And when that crisis hit, the financial crisis, I decided to go spend money. So I went ahead and spent about $200,000 changing the design of my building and putting in my CareStream 9500, which is a full head scanner. And I made the room so I could display the scanner with a mirror behind it. And that was my Ferrari at the time. And it kind of helped us get out of our slump, because we were one of the first groups to be doing 3D imaging for our ortho patients. And I formed a group practice where we had every specialty except pedo. I never could get a pedodontist, but now there's 1,800 employees in our company, and I work with a lot of the pediatric dentists, and it's fantastic for the referrals back and forth. So this is an endorsement, or let's say a very kind email from one of the legends in orthodontics. Dr. Bob Boyd is the chair, or was the chair of UOP San Francisco. He's now professor emeritus, and he's the brains and the first doctor behind the Invisalign software. And he and Jack Choi at Anatomage, I got to fly out and work with them a lot, just learning about 3D dentistry. I interviewed everybody out there for a book we published called 3D Dentists, The Future of Dentistry Is Now. And I had it published on the iTunes store until they told me I couldn't use all the great videos I had in it. So with this time off that I have, I'm now going to put it into a print version. And so I like the time off I have so that I'll be able to get a couple articles finished and get the book in print. So Bob Boyd said he was proud of the family, how we're working with new concepts and technologies in 3D imaging and CBCT. So I want you all to listen to this trailer from Taken.
I don't know who you are. I don't know what you want. If you're looking for ransom, I can tell you I don't have money. But what I do have are a very particular set of skills. Skills I've acquired over a very long career. Skills that make me a nightmare for people like you. If you let my daughter go now, that'll be the end of it. I will not look for you. I will not pursue you. But if you don't, I will look for you. I will find you. And I will kill you.
Good luck.
So this is our practices version of this movie trailer, and I called it Straighten. I'm going backwards, I'm sorry. And we're not going to listen to this again, I hope.
I don't know who you are.
Sorry. Now, the reason I show this in my lectures is to give praise to the implant dental professionals, the whole industry, because we do truly have a special set of skills.
I you're calling the dental specialists, I don't know what you need. You might be looking for affordable braces, cosmetic or implant dentistry. What we do have are doctors with a very special set of skills that have been acquired over the last 40 years or more. If you make a consultation appointment now, we will not charge you. We will give you an expert opinion, treatment, recommendations, and straighten out that smile. Dentalspecialist.com and affordablebraces.com online, or call 800-76-SMILE. Doctors Paul, Jason, and Jonathan Ouellette, Orthodontics and Implant Dentistry.
So I want to give my son a little praise here. He just learned so well, and he's one of the instructors for the CERP Comprehensive Implant Residency Program, which Dr. McCracken and Rosenstiel train several hundred doctors every year. They come into Birmingham, Alabama, 8 to 10 times a year, or 8 months to 10 months. And they get a lecture on Thursday. They do surgeries all day, and the 8 to 10 residents go around doing sedations, taking photos for PowerPoint. And then on Saturday morning, it's the best day. We go over all the PowerPoints from every surgery that was done. And you learn so much from doctors that are learning how to do implants, where they might perf the sinus or not get it in the right place. In most cases, they were trained very well by the instructors, and there was very few major errors, but you learn from your errors. One error was if you don't tie a dental floss around some of the instruments, they can go right straight down the throat. So we had somebody swallow a little driver that they had to go to the hospital and get an x-ray. And so Jonathan was one of the instructors. He's now in about year 6 of his practice. He did 128 full hybrid arches last month. He works with Dr. Joel David in Jacksonville, but his practice is in Orlando. So he's the provider of the D5 teeth and 24-hour system, which is a permanent prosthesis, not a PMMA prosthesis. Now, that's a younger picture of me down in the bottom left, and I dye my hair gray so I look intelligent. So I don't want to go back there. So one of the things, there's a lot of dogma or beliefs in implant dentistry. And the reason I got into doing implants is I would work very hard as an orthodontist preparing receptor sites for dental implants. And then the patient might have to wait 2 or 3 to 5 years because they were young when we finished the case. We would use a flipper. We would use a resin bonded bridge. We would just use things that basically failed and allowed the teeth to relax. So then the patient shows up back at the general dentist or the implant surgeon's office, and they look at the case and they say, well, the orthodontics, we have to go through orthodontics again. It wasn't done correctly. And so unfortunately, I have these patients coming back mad at me. And I thought, gee, I did my best. And the implant site looks wide enough because the flipper or the resin bridge is still there. But I didn't understand that the roots, if they diverge or converge the wrong way, you can't get the implant in there. So what I did is I came up with a way of putting an implant in, a temporary implant that can be put in about 60 seconds and taken out 30 seconds. The longest clinical trial patient I have now is 7 years. He's out in Spokane, Washington. I found him on Facebook, and I got an orthodontist out there to take pictures. That's one of the papers I don't want to publish. I have other cases that are, 4 years, 5 years at least, with the implant and crown still in place. But I ask you all, do you have the special skill set? And then as far as the dogma goes, there needs to be better communication between the orthodontist and the implant dentist. And so this was a post on Osseous News. And the question was, placing implants while undergoing orthodontic treatment. Is it a good idea to place implants with a possible bone graft for a patient while the patient is undergoing active orthodontic treatment? Now, many of you still have the feeling the orthodontist should get all the orthodontics out of the way, get the occlusion where the orthodontist wants the occlusion, and then send the patient, take the braces off, get the patient in retainers, with some sort of a temporization, and then get the patient referred to the implant surgeon, which might put the patient on a recall because they're too young to have an implant. So we all know what happens if you don't put something in there. You get disuse atrophy, and so the site loses bone. And this doctor that was responding to this, who was a very prominent doctor with lots of experience, he was kind of scolding the guy. Well, how could you possibly do reconstruction while the teeth are still moving? Implantology is a restorative-driven discipline. Everything should be set up ideal, and only then, should you put the proper size implant in. And it's not good to do multiple treatments at the same time. And of course, I agree with him with good communication with the orthodontist, but I disagree with him about treatments at the same time. I was trained by Dr. Edward Mills, who was one of the co-founders of the Maxi courses for 20 years or more. He was training doctors to do implants. I practiced with him in his practice, treated all his children, and I learned so much from him. I basically audited the Maxi course about 2 or 3 times because the doctors would come in once a month, and I always was there on a Friday, so I'd go up and listen to the lectures. The rock stars like the Salamas and Hilt Tatum would fly in from France. So I got exposed to that. So then in 2010, I formally took the course. In 2013, I presented cases and became certified as an associate fellow. I'm going to stop there because I'm going to leave it up to my son, Jonathan, to do all the heavy lifting with sinus lifts and laying flaps and so on. And by the way, my implant is aerosol friendly. You don't have to use any tools that produce aerosol. No flaps, maybe a tissue punch at the most. And it's a TAD, basically a TAD with a prosthetic platform. And orthodontists are putting TADs in, hundreds and thousands of them. I've been doing TADs for orthodontics probably 20, 25 years. Okay, so anyways, basically I summarized what I just told you all, that I disagree with the doctor that we should not take the braces off until at least the doctor looks at the implant sites. Maybe we take a 3D image, because x-rays and panorexes lie as far as where the teeth are, and then give me permission to take the braces off. And then do the implant a little quicker. But if the patient's really young, it's a problem, because there's not really any implants that are accepted by the industry that you can call a pediatric implant until now. So when I teach my orthodontic courses, I sometimes get too complicated. So my son, Jonathan, said, keep it simple, stupid. So just tell the implant dentist you want to move the teeth up and down, maybe to generate bone or intrude a tooth, and you want to move them back and forth. We don't want to get into teaching torque and AP, anterior posterior correction, and all the things that orthodontists do, the orthopedics. We got to keep it simple, and we got to keep it 6 months, 9 months at the most, if it's possible. And also, there's a problem with the cost. The orthodontist is going to charge the patient $4,000 to $6,000 for the orthodontics. And then when the implant dentist gets the patient, they get another $5,000 to $10,000 bill. I have been sending many, many patients out to Dr. Mills and some of the very well-qualified doctors in the Atlanta area. And on my website, which I'll have all the links to additional information, tadplant.com, like a TAD, T-A-D, plant.com. On the first page, I show an insurance form where the patient got 2 quotes. One was for $14,000. The other was just under $10,000 for 1 lower implant. Now, of course, there was some surgery, soft tissue surgery and stuff that had to be done there. But how many people can afford, after they paid me $5,000, to then have that expense? So that's why I tried to put something that I call patient affordable implants. And I'm not saying it's a permanent implant. It could be a permanent implant because it's made just like the old Branamark implants. with no surface treatments, just a smooth machine finish, and it can be backed out without harming the site. We're going through a 510K right now, which had to be put on hold here because of the shutdown of the economy. So that's what I try to teach. Now, this is a little thing on 3D, a cephalometric analysis that we created and published on Dental XP. This will only last a minute. So these are the planes, the 3D planes. And instead of looking at a 2D ceph, we do bilateral paired landmarks. Then I came up with the idea of in the middle, it creates a polygon. And so if you did a mid-sagittal plane and you measured the volume on each half of the polygon in the middle, do you think those measurements, that volume would be equal? And we all know the answer is probably no, because there's anatomical variation from one side of the face to the other. Also, we started looking at airways 10 years ago and sleep apnea. And we found many constricted airways. So we were scanning every patient, orthodontic patient, except the real young ones. And we were checking for these things. We were learning about incidental pathology. We found many tumors and things that we sent out to the proper doctor to treat it. Now I might have pushed the wrong button again. So let's see if I can try this. Here we go. So let's get into a case here, and I have a timer on because I don't want to go beyond my time here. Okay, good. We still have enough time here. So this case was one of my learning cases to learn how to do certain things in dentistry that orthodontists usually don't do. I have a periodontist colleague in Melbourne, Florida, very prominent guy, that was thinking I was crazy because I was getting into his turf. I was doing surgeries and learning how to do all this stuff. And I wasn't trying to compete with him. I was just trying to learn. So he sends me a little note telling me, well, good luck. And at the bottom of the note, he had taped on a little Band-Aid for me. So in case I cut myself doing the surgeries. Well, I want to tell you, about 5 years later, I sent him a thank you note, for sending the Band-Aid. I sent him the Band-Aid back that I really didn't need it. So we use 3D CBCT for all diagnosis for our implant patients. We did a Smile Design wax up at the time. Christian Coachman was just coming into the picture. He practiced in Atlanta, or he was the head of their ceramic lab for the Salamas and Goldstein and David. I can't think of David's name. He's awesome. I can't think of his name right now. So I learned how to use a positioning splint, so that after I got a wax up, they would make a little a stint out of a putty. In my video that you'll see, I call it polyvinyl. I think is a different material. So I would learn how to do dental implant site engineering with anatomage. This case happened to need perio for some bone loss on areas 12 and 13. So we had a LANAP, what do you call a LANAP? A periolace is what it's called. Also, I learned how to do soft tissue emergence development as an orthodontist. And I also learned about when you put implants in, you get dieback. So these are the take homes that I learned. So here's the case. She happened to have a cyst up in the front of her mouth between 8 and 9 that we picked up in 3D. It doesn't really look like a cyst, but it was. And so she had to have that worked on. In the area of 12 and 13, there was some perio problems, and you can see there on the lower left side, the molar had an abscess. Okay, so here's Miss Heather. She was a 39-year-old patient, And the reason that she had all this problem, she got kicked in the mouth as a younger patient. So 8 and 9 were injured to the point of root resorption, and there was some external root resorption. So we had to eliminate those teeth. And now we have a space problem that I had to figure out how to set up the teeth so we could restore her. So that's a frontal picture. And this could have been a little bit of periodontal migration, which I see a lot of patients will come in and the teeth just start spreading. And of course, I work very closely with my periodontist and make sure that we don't treat anybody unless they're being monitored every 3 months. So the extractions of 8 and 9 were done, and 19. The LANAP procedure was done. While you're watching this, I'm going to get a little glass of water and I'll be right back. This is so much better than a podium presentation because I can actually excuse myself and go get a drink. So anyways, most of you are probably familiar with the LANAP procedure. Now, this patient I used for my case report for the AFAAID. And my son, I've been telling him, you've done so many implants. He put in like 1,000 implants last year. And I said, why don't you take the certification? And so the only reason I did this was because I practiced with Dr. Patrick Williams. He was one of our associate doctors. And he and I took the Maxi course together. And he was a super surgeon. And he's down in West Palm Beach now. And so he helped me with this case. And he really held my hand. And I got to tell you something that he did for me here. When I was doing the putting the implants in, actually, it was not this case. It was another case where I was putting lower implants in. So he took the denture, the old denture the patient had, and he took it into the lab and he took all the lingual out where the implants were supposed to go and made me a homemade surgical guide. Now, I was using anatomage, when I was developing the TAD plant because I could go online and pre-plan it. But I don't lay flaps, I don't do sutures, and I don't do shots. I'm an orthodontist, so all we do is point our fingers. So it was really a new learning curve for me to learn how to do all this stuff again. And thank God I have a son that can go ahead and do heavy lifting cases. So this is just some of the write-up that I did to go ahead and get certified. And this is the radiology report. And the radiologist actually missed the cyst up in the, she said it was like 8 millimeters and 10 millimeters was to call it a cyst. But anyways, we took care of that. So this is some more of the 3D imaging that I've been working with since 2009, 2008. My son was trained in Bogota, Colombia, and he actually was working with 3D imaging maybe a year or two before it got introduced to the United States. I think they had a cheaper price they would sell to South America. So they had scanning labs down there, and some of his teachers owned the labs. So he got to learn about this before I did.
Okay, well, here we have our patient Heather, and we're using some adjunctive orthodontics to prepare the implant sites for teeth numbers 8 and 9. We have used a lab-made index, which is made out of a polyvinyl material. Open, Heather. And we can put this index in to see exactly where we are. We have orthodontically wanted to move this tooth mesial and also the other lateral, number 7, we wanted to move it mesial. Well, I already have accomplished getting number 10 exactly where it should be. There was a wax up that we did that showed the ideal proportions for these teeth. And so we're using this as an index so that when I'm orthodontically moving the teeth, that I get them precisely placed so that we get the implant or implants in there. And then the final crowns will be exactly as the diagnostic wax up. Also, while we're orthodontically treating her, we put some Pontics on the arch wire. We also have some springs that keep us from moving too far. And today we took an impression for a flipper because we're getting close to being finished, and we want to maintain this space being open between numbers 10 and 11. And then I'm going to put some active coil here today between teeth numbers 6 and 7 to try to get a little more room there to create the ideal space. These Pontics were made small on purpose so that we had room for the teeth.
So looking down on the lower left part of the screen, the tissue conditioning Pontics, ovate Pontics, I learned that from Dr. Williams. And so I built that into the design of my implant so that I would have tissue sculpting attachments, healing caps and so on, so that I could actually create a really nice, spot for the temporary crown. Now, all of our implants and crowns are provisional. I have a lab in Atlanta that I'm partnered up with, European lab, that basically will do all the lab work so that everything's provisional. So screw retained on a TAD plant. So it's a 2-piece implant. It's not just a TAD. So this is pictures of some of the things we had to use with the little stent there that we got the teeth in the right position. Now with Christian Coachman's process, you can do everything digitally, and we are doing digitally. We're not using his program yet. I'm still concentrating on orthodontics, and I don't know if my son Jonathan has signed up for his program because he does all final prosthetics. I'm mainly doing the provisional. So you can see the spacing that I got the laterals a little further forward, so we didn't have such big horsey looking teeth, and you can see how the tissue is sculpting. And then before we had a program called Smart Tooth, SmartTooth. It's a little free download from the iTunes store. It's an app. All you do is put in one tooth, like the central. If you put in 10 and just push the button, it automatically shows you the proportions. It'll show you the proportions for the length and width of the teeth. And so I use that now, and I take a screenshot and I send that to the implant dentist I'm working with, telling he or she, this is what I'm going to do unless you tell me different. So here's Miss Heather getting ready for the implant surgery. And this was an open flap procedure, and I almost fainted, but Dr. Williams was there to help me, and he made a splint. As you can see, it's like an Essex appliance that gave me the palatal limit. And then also the labial limit is the arch wire. Now, Dr. Mills, when I do cases with him, he wants the braces on the teeth. So, and he leaves the arch wire in and does his surgery. So he gets the implants perfect every time, not only because he pre-plans them, but also he'll use guides like the arch wire being in. So when I said in the beginning that you don't do all the orthodontics until you put the implants in, you work with the implant dentist, and then you'll be able to take the braces off after the dentist will make an ideal provisional crown at the right dimensions, and then I might close up the space. I'll open the space a little more on a lot of cases, so you can safely get the implant in, and then we close it down. And so it's just a little different way of working, but I've been doing that for like almost the last 10 years with the doctors I work with. Now, before that, I had a couple cases, as I told you, I got criticized. And one case, the implant dentist sent the patient to his orthodontist over in Orlando. I was on the coast. And of course, the orthodontics was done incorrectly or whatever, and it's going to have to be redone. So I had to write a check for $5,000 back to the patient. So that was the first tuition I paid on learning how to do this myself. So it's sometimes when you have a event like we're having right now, we're going to learn a lot from this event that we're going through. that taught me that I better learn a little more about what I'm doing and work better with my referring doctors. Just some more pictures just showing the stages of the surgery. Some x-rays, and look how much buccal plate is left. That's great. I was taught that the buccal plate is sacred. So when I put a TAD plan in, I always put them in way to the palate and try to preserve the buccal plate. And also orthodontists study growth and development. So the maxilla is actually a moving target. It's growing down about 6 millimeters and inward palatal about 2 millimeters. So the crest is moving. So we're putting implants in young patients in a moving target. So that's one of the things that when I talk just about the implant system, you have to take into growth and development. And then there's another thing we have to worry about, which I'm an expert in, and that's called aging. So there's a lot of changes that occur as you age, loss of vertical dimension, and the implants stay right where the doctor put them, but the bone is remodeling and going away from sometimes where the implants were placed. So my idea is not to think of an implant as a permanent solution, like 95 to 100% integration. That's a success. That's not a success if the patient is remodeling or aging. So you have to take into consideration that you might have to relocate the implant and redo it. And no restoration is really permanent. Everything's provisional. Even the orthodontic cases we treat are going to be changing over time. And we're retreating a lot of the cases we did years ago with Invisalign and maybe a little simpler process to realign the teeth. Of course, we use PRP. I learned how to do all this. And I just started thinking about all the steps to put implants in. That's why everybody has that special set of skills that do implant dentistry. It's so complicated. You have to drill like 3 or 4 holes. You use tissue punches, or you lay a flap. You use the biologicals. So I wanted to come up with a very simple way to put an implant in like the orthodontist puts a TAD in. I don't even have to surgically scrub like I have for all these types of procedures. We keep everything sterile and clean in an orthodontic environment, but usually it's open bay, which that's going to change now that we have the viruses that are probably going to be spread if we don't put some partitions in. So there's a lot of changes we're going to have to make. But one of the nice things about the TAD plant, doesn't produce any aerosol, and it goes in about a minute. So here's my son teaching some of the residents, not the residents, but some of the general dentists that came in to learn how to do implant dentistry. He does this every day. And so we're getting towards the end of this case. And I'm showing you from the wax up to trimming the ovate pontics. And then there's different types of pontics. So we take this into consideration when we place the temporary implant. A lot of times it'll be so far palatal that we have to stretch it out like a ridge lap. So I started thinking, well, geez, that's a cantilever. Mish taught me not to do cantilevers. So then I started looking at hybrid denture design, and a lot of the hybrids my son does, and the ones I've seen, through all the experience I've had going to lectures on this subject, the screws seem to be way to the palate a lot of times. Sometimes it's in the occlusal table somewhere, and a lot of times they're in the palate. So if you can hold a hybrid prosthesis that way, it's very easy to hold 1 or 2 crowns the same way with a temporary implant. And that's the way I've been doing it. And on the TAD plant website, there's a evidence tab. Actually, it's a second tab. And there's several articles showing what orthodontists in Sweden, Melson, I believe her name was, she's putting implants in way to the palate and then using a wire to extend the temporary prosthetic tooth, and then putting a couple horizontal bone screws to maintain the ridge of the patient for 5 years until they mature. And the implant site did not need bone grafting. It's a great article, and I'll give you the references at the end of this. So this is just showing, developing the temporary prosthesis with the ovate restoration to create a really nice socket for the tooth. And I believe these were pica abutments that we were using. Yeah, you can see the nice development of the, where the tooth is going to look like it's growing right out of the gum. So as an orthodontist, I learned how to sculpt tissue. I never thought I would go there. And we did an implant on the left side for this patient. Now, Dr. Patrick Williams put the ones in, put the number 19 in. And so here she is, final images. And then the die back, you can see a little die back. And this is no big deal because it's been in there for a long time. A little die back is okay. But then peri-implantitis could change that. So we like to monitor our patients at least every 6 months that have had the implants. Okay, so let me see how much time we have. A couple minutes left here. This page basically has all of the links to get more information. I have several lectures on ViewMedi, Dental XP. We're putting together a quick smile virtual exam that will be no charge to orthodontists to use to do virtual consultations. I've also made it so I can do consultations for implant dentistry for my son. We have a braces help app on the iTunes store, and right now I'm having it programmed to be on Android, and there's a website for it, and it's no charge. And basically, it'll have anything that's you need to know about implant maintenance, and also the same thing with the braces. We had one of the first virtual emergency services because we published this in 2010, and there was a tab you could push on it and they could take a picture of their emergency and send it to me. And so I was communicating with my patients with my iPhone from 2010 on when we first put this up on the internet. So now we have to go to the next step, and this will be a big part of dentistry in the future. The D5 Ultra is a 24-hour teeth. You can see about that with that thing, that link, I'm sorry. We have a YouTube channel with about 38 videos on there. And tomorrow we're doing a teledentistry international conference with Bob Boyd will be on the panel. And the link is right there in the square box if you all want to join us. I believe it's 12:14 right on my clock, and I'm supposed to finish in 1 minute. Is there any questions? Is anybody there?
Yes, sir. Thank you.
Yes. Yes, I finished, I think, right on time, correct?
Okay, thank you, Dr. Ouellette. It was really a beautiful presentation. We
Well,
have one question by Dr. Gagandi. She
Yes.
has asked, erbium YAG lasers usually are used for hard tissues. Sir, you use it for soft tissues. Does it not cause carbonization or charring of hard tissue?
Are you talking about the temporary implant?
Yes, sir. She has asked this, that you have used these laser for hard tissues. So,
You're talking about the laser, the LANAP
Yeah.
laser. Yeah.
Yes, sir.
Yeah, it's used mainly for soft tissue. We did not have a hard tissue laser, but it goes in and it just basically ablates everything and removes all the bad, the bad bacteria and everything, and then then you clot it after you're through. Now, I don't do the LANAP. That was Dr. Williams. That was the expert on that. So I do not do the LANAP procedure. I'll get in trouble with my board as an orthodontist if I go too far. So I try to stay right in the orthodontic lane and just develop some solutions for young patients that might need implants while they're developing and growing. And also for patients that don't have money, you can put these in because it'll hold the bone for a while until they can save up for a permanent implant.
Okay. Thank you, sir. Thank you for sharing your knowledge on orthodontics and implant dentistry. It was really a wonderful session.
My pleasure. My pleasure. I really enjoyed this.
Thank you, sir. Same.
Everybody stay safe and healthy.
Thank you. Now we are ending with the meeting.
Okay.